Good afternoon. It's a pleasure to be here, and I would like to thank Nestlé and the organizers for inviting me to be here. It's a great honor to talk to you about one of my passions in my clinical practice, which is malnutrition, sarcopenia, and also frailty. Is it a common denominator, and is it indeed a cornerstone in the management of ONCOGERIATIC patient? So indeed what we know so far, and this is not new for any of you in this room that know much more about this than I do, I would say, how common is cancer in older adults is extremely common, because we do know that cancer is primarily a disease of older people, and indeed more than half of the newly diagnosed cancers occur, and 71% of the cancer deaths indeed occur in patients and people above 65 years old. As you can see here in the prevalence and the data on the newly diagnosed cancers, they are indeed prevalent in the older individuals. About malnutrition, and when we talk about malnutrition in the older adults, we do come with a joint problem, because the older patient is a more fragile and vulnerable individual, and when we talk about cancer, with all the consequences of the cancer disease, we do have a much more complex problem. This is one of our studies that we have published 1.5 years ago. This was conducted in the oncology department, and the median age of the patients included was 65 years old. And what we found in this study was that 1 month before the referral for chemotherapy, 34% of the patients had lost weight with a median variation of 6% from their actual weight or usual weight, and more than half of these patients had lost a significant amount of weight with a median variation of 10% in the previous 6 months before the start of chemotherapy. And when we looked into nutritional status of these patients applying the PGSGA, which is the validated tool for cancer patients and for oncology, what we found was that only 12% of this cohort of patients was considered to be well-nourished, and moving forward on the completion of the PGSGA, 84% of the patients in this cohort scored more than 9 points, which indicates that they did have an urgent necessity for nutritional intervention. We do have, and we do know, and the literature has shown this with very little doubt, just as it has been mentioned by the previous speaker, we do have major consequences of malnutrition in older adults with cancer. We do have an increased toxicity to the chemotherapy and the anti-cancer treatments overall. We do have the increased risk of the developing sarcopenia with a major impairment in their functional capacity, dependence, the frailty, and reduced quality of life. We also know that these patients, when they become malnourished, they reduce their tolerance to the anti-cancer therapies and treatments, as surgery as well. They do have more complications, more severe complications, and increased risk of infections, and longer risk and higher risk for longer hospital stays. When we talk about sarcopenia and frailty, we do know that malnutrition can indeed exacerbate the development of frailty and sarcopenia due to long-lasting deficient intake, specifically on a substrate which is nitrogen, protein, but also energy intake that can lead to major weight loss in these patients, but also cancer comes with a multitude of metabolic disturbances and alterations, and they all contribute to the installation and the development of malnutrition and of sarcopenia. This is another paper that we have published last year. This was conducted in a different cohort, in a different patient population, metastatic colorectal cancer. Median age in this study was 62 years old. They were all patients referred for first-line chemotherapy. And what we found, we focused on body composition assessment. What we found was that the patients that had sarcopenia at referral, and even before they had started the chemotherapy and the first-line therapy, they did have a higher risk for a much reduced survival time when compared with the patients in the green line, which are the patients that did not have sarcopenia. We also found a trend for a significant difference between patients with sarcopenia versus the patients that did not have sarcopenia for the ECOG performance status, and also for systemic inflammation that seemed to be much more exacerbated and more severe, given here by the neutrophil lymphocyte ratio in those patients with sarcopenia versus the patients that did not have sarcopenia. In another study that we conducted in cooperation with the University of Helsinki, in patients with head and neck cancer, what we found was that when we evaluated the nutritional status of the patients before they started concomitant chemo and radiotherapy, and here it was with curative intent, what we found was that the patients diagnosed as cachectic at the start of the treatments, they did die earlier, and they had a much more unfavorable outcome from the treatments, and 1/3 of these patients had cachexia with a significant association for a shorter survival. In another study that we have just published also last year or 8 months ago, I'm not sure, where we included also patients with cancer of the head and the neck, and here we applied the GLIM criteria as recommended by ESPEN. The median age in this study was 61 years old, and what we found is, as you can see here very clearly in the blue line versus the red line, with malnutrition versus the well-nourished patients, what we found in association with the outcomes and prognosis, malnourished patients had significantly lower overall survival, but also disease-free survival than patients that did not have malnutrition, given by the GLIM criteria. So to summarize the data given by these studies and this big data that I consider to be key for us to understand the implications of malnutrition, sarcopenia, frailty, and cachexia, what we see is that all these parameters, all these entities do not come separately. They occur many times concomitantly and many times as a sequence. So we do need to understand that we also need to detect the common denominator of the nutritional deficiencies that these patients have, older adults with cancer, which is indeed a reduction and a significant reduction in the protein intake, and also the metabolic disturbances that do require a multimodal care intervention. And because of this, this was what we gathered together for the ESMO guidelines, which was a collaborative project with ESMO and ESPEN. What we gathered together for the multimodal care intervention was that indeed all healthcare professionals are involved in the decision-making process and in the treatment process of these patients. That include nurses, dietitians, psychologists, social workers, physiotherapists, and naturally the oncologist, the geriatrician, and the support and rehabilitation specialists should all talk the same language in terms of exercise and in terms of nutrition care, so that indeed the message can be more efficiently integrated in the clinical practice. So our main objective with nutritional intervention in this population is to recover or maintain an adequate body composition and nutritional status, and ideally the physical and functional status of the patient, to try to correct the nutritional deficits in macro and micronutrients that the patient may have, to reduce the frequency and the duration of the treatment interruptions, as we know is a major problem that compromises significantly the prognosis of the patient, and to reduce the risk of re-hospitalizations in these patients. And also, and concomitantly with nutrition, it comes the stimulation of physical activity, which is mandatory nowadays, to try to reverse the picture of fragility in these patients and moving the patient away from the situation of incapacity. Because what we need to do and what we need to foster in clinical practice, as it has been recommended in 2019 in a very interesting paper by Mary Apro, is that we need to evolve from what we do nowadays, which is much more an oncological classical pathway that focuses on the study of the disease, and all the investments in terms of therapy is on the disease staging, the cells, first-line therapy, second-line therapy, and try to move forward and integrate all the information that the nutrition data can give us and the body composition analysis can give us and the implication that it has in terms of prognosis, and try to integrate it in the decision-making process so that we can offer the patients the state-of-the-art cancer treatments that we need. In the geriatric field, physicians do have several tools, and this is only one example. I mean, by looking into this scale, very easy to apply, we do find that when you have an older patient with cancer that is considered to be relatively healthy, then he or she might be considered fit for a curative treatment, for a treatment with curative intent. But if the patient is malnourished, then it is considered to be vulnerable with a necessity for adaptation of the anti-cancer treatments. If the patient is diagnosed as frail, then we might consider to implement palliative treatment or treatment with palliative intent. When we look into the nutritional intake in these patients, and this was a questionnaire that we have performed in consecutive patients with solid tumors, we do see that in terms of protein, in grams of protein per day, the majority of the patients do have a major deficiency in terms and much below 1 gram per kilogram per day, which is also much below what we have stressed in the most recent guidelines at ESPAN that we have fostered and tried to implement until between 1 and 2 grams per kilogram per day with the necessary adjustments in terms of elderly patients. When we go through the decision-making process, our priority in terms of nutritional intervention is naturally the oral nutrition with the necessary fortification with the use of ONSs when necessary, education of the patient in terms of nutritional advice. If this is not enough, then we need to apply medical nutrition with enteral nutrition, parenteral nutrition in case that oral nutrition route fails or it's not enough. And concomitantly, we do need to implement and foster exercise and exercise education as well, specifically in older cancer patients for resistance training to try to foster anabolism and with this counteract frailty. In terms of food choices, fortifying foods, and oral nutritional supplements, they have been associated with greater patient compliance when we use regular foods, and this has major issues and the patient cannot comply and cannot achieve their necessities only with regular foods. It has been identified to be important specifically in patients which are symptomatic, to include ONSs. Consider taste loss and alterations that these patients present, and with this a variety of flavors is also important, and the formulas that have high density in calories and protein and low volume are also associated with better compliance. Globally, what we are in my view, and in terms of my clinical practice, what I see from the studies that have been conducted is that we need to move forward implementing an assessment that should be focused on outcomes, and specifically for those high-risk patients. What I defend in the clinical practice in these patients is somewhat similar to what I see in other areas of medicine. Just as we have a green way for stroke, a green way for sepsis, or a green way for myocardial infarction, I would like to have a green way for nutrition where we do prioritize those patients at higher nutritional risk for a faster intervention so that they could be protected in terms of their nutritional status. And in this tentative approach, this is a practical protocol that we have developed in Portugal with a multidisciplinary team, exactly to try to foster a faster referral of cancer patients to individualized nutritional treatment. What we have recommended in this protocol was that globally we screen patients as not at nutritional risk or at nutritional risk. Inside the risk of malnutrition, we have the low risk, medium, and high risk, and as considering the level of risk that we have identified, then the patient should move forward in terms of referral and in terms of consultation. And we have recommended the inclusion of the several healthcare professionals. If the patient is in low nutritional risk, a nurse or a physician could be, or a geriatrician, could be in charge of providing some basic information in terms of the diet. If the patient is at medium nutritional risk, a nurse or a physician should also be included in terms of elucidating the patient on the food choices and try to mitigate also the symptoms, and these patients should undergo a detailed analysis of the weight loss, of the symptoms that they present, and the functional capacity. And those patients at higher nutritional risk, then they should be referred for a nutritional specialist, a dietitian, or a clinical nutritionist. This is only one tentative protocol. What we do need to, and we do, and you do for sure, is to value heterogeneity in this specific population. We do have a major heterogeneous population with various combinations of comorbidities, physiological reserves that differ dramatically, deficiencies, and also geriatric syndromes. And indeed, what sarcopenia gives us is a chance to try to tailor our interventions to better treat these patients. These are my take-home messages that you have been following throughout my presentation, and I would like to share with you my last slide, which is this one. This was a picture that I took last April in Museo di Zoologia in Italy, where these were pictures taken from an old hospital, where in the 1900s, clinicians already used weighing scales, and this is a weighing scale with a stool for those patients that can stand. And these are dynamometers, because they did consider to be essential to try to understand the functional capacity of their patients, because it was indeed, they considered already at this time, they considered to be important for the prognosis and for their understanding of what to expect from the patients. Thank you so much.